Health Insurance Authority, Dr. Kwesi Djokoto. Doc, good morning to you.
Good morning, my very good friend, and I'm happy to be here today.
It's nice to have you
It's good to see you doing well.
Oh.
I mean, God bless you so much for the work that you've been doing for us. I've been following you for so many years, and I can say that your contributions to our democracy in this country is immense, and God continue to strengthen you. My warm regards to all your loyal listeners. I'm actually one of them. So
thank you.
I'm
You're
here
too
today.
kind. Well, look, as joining us to talk about free primary health care. You know, this morning, even if we decide to even talk about national health insurance scheme, it's a whole 2-hour interview. So what we'll do is that we'll try as much as possible to limit this to free primary health care so that we do not go, because Doc himself has been within our healthcare system for many years.
Yes.
At one point in time, we were Director Health Services for Volta Region.
Yes, Regional Director of Health Service for the Volta Region.
Okay. The two works, being Regional Director Health Services within the Ghana Health Service system.
Yes.
And then working with National Health Insurance Scheme. Is there any relationship?
Oh, yeah, that's a very strong relationship.
Okay.
In that, I mean, for the National Health Insurance Scheme, first of all, we are also advancing the same health objectives. So, universal health coverage.
Okay.
Just that one is on the service provider side and one is on the health financing side. Before you finance something strategically, you actually have to understand what the system is.
Okay.
Yeah, so that, you know, when you're engaging them, you reach a good consensus on what is beneficial or what's not beneficial, or what will be most beneficial to the people of the country. So it's complementary, and I can say that I couldn't have been at a better place at this time. I'm grateful to the president for this opportunity.
So from service provision, you move into financing.
Health financing, yes.
Yeah. Are those, because many people are expecting one side, maybe may not be so familiar with health financing, service provision. Is health financing part of the things part of your expertise?
Yes, health financing is part of my expertise. I've had the opportunity to also do an MBA in finance from the University of Ghana.
Okay.
So I understand finance. I've been at the receiving side of health financing as well. And before you can take any decision with regards to health finance, you have to have an in-depth understanding of the health systems. So that will make you take decisions that will inure to the benefit of the system. And when you look at the health system building blocks, health finance is certainly one of the major blocks. Everything else revolves around it. So if you're talking about logistics and equipment, certainly revolves around health financing. If you're talking about a human resource capacity, it still revolves around health finances. So you have to have an in-depth understanding of the health systems to be able to make the right impact.
Well, like I said, I would have continued on that chain and moved into health insurance. But let's come to free primary health care. First of all, the concept itself, free primary health care, for someone who's worked within health provision, service provision, what does that mean?
So I'll tell everybody that as a public health expert, this is one of the most significant moments in my professional life.
Significant?
Very significant, if not the most significant. We've made a lot of strides as a country towards achieving the universal health coverage goals. But like the president said yesterday, there are still some existing gaps that need some radical reforms. And these radical reforms obviously includes the health financing regime that we have in this country. So what are the significant gaps that we still have? Number one, we still have gaps when it comes to the equity gaps. So people within rural areas or semi-urban areas do not have as much access to healthcare as those who are within urban areas. And even within urban areas, you have varying levels of access to healthcare.
Okay.
So that's one thing that we are looking at. We have quality gaps.
Okay.
So you go to certain places, they have all the equipment. They are able to get the right standard of care, but you go to others, they are improvising.
Okay.
So those are significant gaps that exist within the system. Then you have non-communicable disease trends now. So there's something we call epidemiological transition.
Okay.
Now that the world is facing, specifically in Africa. So we still have a significant burden of what we call communicable diseases. So malaria, TB, HIV, AIDS, and so on and so forth. And in addition to that, now we have non-communicable diseases, which is disease conditions like diabetes, hypertension, and cancer. Some people actually add mental health to non-communicable diseases and road traffic accidents. So these are currently a heavy socioeconomic burden on us as a country. And if you review the data across the world, you notice that the incidence of non-communicable diseases in Ghana is one of the highest across the globe, actually. And it is responsible for up to 50% of all deaths that we experience within this country. Now, complications of non-communicable diseases. So you go to most hospitals, when they are doing their top 10 causes of mortality, it's certainly related to non-communicable diseases. So people who have had cerebrovascular accidents or strokes, as we call it, people who have had myocardial infarctions or MI or heart attacks, as we call it, people who have had complications from diabetes and have had chronic kidney disease or kidney failure and have passed on from that, people who've had breast cancer, cervical cancer. You put all this together, you realize that they are now by far the leading causes of mortalities in this country, the leading causes of deaths. Let me break it down simply.
That's problematic.
Yes, so this is problematic. So we need certain radical reforms. And you see, the last one that is actually also very important is sustainable health financing for primary health care interventions. You know the global context in which we are now. The withdrawal of the USAID funding that has affected quite a number of development partners. You would have necessarily expected that some of these interventions are paid for sustainably by them. But now it is intermittent. It comes today, it doesn't come tomorrow. And certainly it would affect our ability to deliver healthcare to the good people of Ghana. So our president again led this Accra Reset agenda, where we are looking at African sovereignty. We defining our relationship with the development partners and taking ownership of our projects, even by way of looking at within country means to fund some of these activities. So all this put together would give birth, or is what gave birth to the president's vision of free primary healthcare. And what simply is the vision that every Ghanaian, everybody resident in Ghana, should be able to have equitable access to quality primary health care at no cost at the point of service delivery. And this would certainly improve health outcomes and also adhere to the socio-economic development of Ghana. So this is the president's vision that we are bringing to reality through the free primary health care.
Very interesting foundation you've laid on this matter. Now, there's also what exactly this will mean. So we have free primary health care. So what are you defining as primary health care that is free to the Ghanaian? At what stage do I know that I am past the primary health care stage? What are the dynamics that operate
here?
So
the primary health care is the first point of call in every developed health system. So we are developing health systems. So I would admit that some people can even walk straight into regional hospitals or walk straight to Kolebu to seek healthcare. Is not supposed to be so. So the primary healthcare usually is the first point of call. That is where you have the CHIPS compounds. So the CHIPS compounds are usually community initiative. You have community health nurses, community health officers, midwives. They would usually undertake preventive, promotive initiatives, and also they would also look at treatment of minor ailments. So that's where they actually see you first. When you require referral, so the primary health care facilities are the CHIPS compounds, the health centers, the public health units of polyclinics. Usually when they see you, then they will refer you to the district hospital, or then from the district hospital, if you need further specialized care, then we refer you to the secondary hospital. So these basically are the regional hospitals in the various regions. Then beyond that, you are referred to the teaching hospitals if you need subspecialized care that would not exist in the regional hospitals. So this gives you a snapshot of the health system within Ghana.
So from CHIPS compound to the polyclinic level?
Yes, CHIPS compound to the polyclinic level. That is where we are going to make free. And we would have to explain that making it free is just not a matter of playing to the gallery. It means improving access, because truly people are not able to pay out of pocket for some of these medical or health services. And it is important as a country that collectively we have a commitment towards ensuring that everybody has access to universal health care. So this is actually the gravitas, or the main reason for this policy, access. So when one has a national health insurance card at this point, and you go to the primary care level, and you are seen. If you have a health insurance card, you will be seen. But if you do not have, then you have to pay out of pocket for curative services. So
that's the status quo now.
That is the status quo now. And we are changing that. Because we don't want the case where people have a certain medical condition, but for lack of money, they are not going to the hospital. Now it gets very complicated, and the family will now have to come contribute out of pocket. Let's send him to the hospital. Then it will cost more effort to actually treat the person. So the person is perhaps a farmer, loses more days of work, now is not able to fend for the family. You know the implications on socio-economic development. But if you make it free and the person is able to walk into the hospital or the primary care facility, gets treatment on time, early detection, we put in intervention, less days off, the person goes back to work to contribute productively to the development of this country. So the policy encourages everybody to still have the national health insurance card. But if you walk into any of our primary care facilities without any identifier, we are looking for the usual Ghana card, national IDs. If you don't have it, we will still help you generate a unique identifier with our systems. So you take your full name, your date of birth, your age, where you live. Then we create this unique identifier for you. Then we facilitate you getting a national health insurance card, because if we pick something like diabetes, it will still be important that you have financial protection when you go to the district hospital, and that financial protection would be given you when you have that national health insurance card. So that is one aspect of the free. The second aspect of the free is the focus on preventive promotive. Early on, I just told you the burden of non-communicable diseases in Ghana, and the fact that 50% of our deaths is attributable to non-communicable diseases. What is the best way to curb or reduce the occurrence of these non-communicable diseases like diabetes and hypertension. It's through screening that will enable you to detect them early. Now, that service is not being offered for free in our CHIP zones, our CHIPS compounds. It's not part of our benefits package as National Health Insurance Authority. It's not part. So
if you want to check your sugar level,
you have to have a way of paying for it. It's not for free. So now the president realizing it, and you heard him eloquently actually explain it yesterday. And as a public health expert yesterday, I was so impressed. And when the president speaks like that, then 80% of your work is done for you. So all we have to do is to complement it. You see, people need to know their status. You need to know whether you're hypertensive or not. It's a simple blood pressure check, but it's something that eludes so many people. So we speak to people about the essence of it. That's health promotion. Encourage them to take on good health-seeking behavior. They come, we check their blood pressure. If it's high, we refer them. If it's not high, we give you counseling on healthy lifestyle so that you sustain it. The same for random blood sugar. We want to know whether you have diabetes or not. You come, we check your sugar level. Well, if it's borderline, we give you counseling, nutritional counseling, exercise, physical activity, and all that, so that you will be able to prevent it. If you have it already, we refer you. You have your National Health Insurance card. We see you. Same with breast cancer screening. That is something that we would also be doing. You know, the number of our sisters, our partners, our wives, our mothers who have passed on due to breast cancer. And the good thing is that it's actually preventable. There's no reason why it should get to that point. So if you do the screening, we pick a lump early, we refer you. You are seen to. We also have mental health conditions that usually they linger on for so long, they get complicated, and these people sometimes, unfortunately, cannot render any productive service to the country. So we pick it early, the full spectrum, whether it is anxiety disorder or it is depression, all the way to what we call schizophrenia, full-blown mental health conditions. We pick it up, and then we also refer for treatment. We are looking at conditions like sickle cell disease, our newborn children who have sickle cell disease. Yes, first of all, we would have done the counseling for partners to see if they are compatible or not and offer the right advice. But those who still skip that route and happen to have children with sickle cell disease, the earlier you pick it, the better. So we pick it. We do the sickling test. We refer you to the district hospital. We do what we call HB electrophoresis. It will tell us whether you are SS, you are SC. These are all various variants that would need some kind of intervention. We pick it, and that one too is free of charge. When we pick it up, then we put in interventions for you. Another thing that would be included is the developmental screening for our kids, vision, hearing. It's important because you see, go to some of the rural areas, and I've practiced before, like you know, in difficult terrains in this country. I've worked in Navrongo, I've worked in Techiman, I've worked in Joje, I've worked in Nkwanta North, Basa. I've worked in Nkwanta South, Nkwanta. So all the places, Pusupu, Bontebo, Breweniase, those are places I've practiced. I've practiced public health. These places actually would benefit from these interventions. You see, the kids who go to school, they will come back, they are not performing well. usually the parent is worried, but they don't really understand it. And then with time, the kid becomes an outcast because the kid would even lose confidence in him or herself. But it could have been just vision.
Okay.
The child goes to school, cannot see clearly what is the teacher is writing on the blackboard. So every day the child is trailing behind the colleagues and the child falls off. Sometimes it's hearing impairments. You see, when these things are picked early, then we are able to work on it. You see, in delivering public health interventions as well, you need money to do community outreaches, and that funding has been coming intermittently. We've had something that we've called CHIPS. We had COVID-19 support for public health activities at a point, but that stopped. If you speak to any community health officer, they will tell you the difficulties they are having in carrying out even routine public health activities that are already being paid for by health insurance, like antenatal care, postnatal care, child welfare clinic, where we call weighing and all that, and then immunization. You see, they are having significant challenges because you don't have the funding to move around and do that. And it affects our coverages as a country. When it affects that, it means that we are going to see more of these disease conditions. So this free primary health care also takes into consideration some of these administrative costs. This will be sent prospectively. When I say prospectively, ahead of time, based on your population, the National Health Insurance Authority, in conjunction with the service provider. So we send it to you ahead of time so that you procure your logistics. You're able to have your movement plan, your community debtors, where you are going to do your screening and all that. So it would eventually strengthen primary health care delivery within our country. And the health outcomes would certainly be good. So this has actually been thought of clearly. A lot of in-depth analysis have gone into this. We've engaged subject matter experts. We have engaged people who work within the field. We have engaged people within academia. And sometimes I walk into some of those meetings and you see everybody who matters in public health sitting around. We've been doing this since April 2025, a whole year. Trying to see how we fashion out such a policy. So I was not surprised when Ghebreyesus Tedros, the WHO Director General, tweeted yesterday that this is a great intervention for the people of Ghana. And worldwide, they are encouraging a lot of lower middle income countries to also have such interventions that will improve access to healthcare.
So this has taken some thorough work. Because there was a promise made in the NDC manifesto. So you're saying that the NDC did not just say, we'll do it and have come and have decided to do it. You're saying since April, you've been engaging the health sector, the academia, and coming up with a policy.
Everybody's contribution is there. We've engaged stakeholders beyond what I've even mentioned. Ghana Registered Nurses and Midwifery Association, the Ghana Medical Association, pharmaceutical stakeholders within the pharmaceutical industry, community practice pharmacy association, and so many people have been engaged. We've engaged the Parliamentary Select Committee on Health, and that has both MPP and NDC members. We've engaged chiefs, we've engaged the service providers, Ghana Health Service, and so on and so forth. So we want everybody's input into this very logical intervention. Obviously, we are a country that learns. We've learned from the suboptimal implementation of the free SHS, and we do not want the same thing with the free primary health care. So we had to put in in place a lot of these measures to ensure that by the time we fully kickstart this implementation, we would not see a lot of those disruptions. It should benefit the people of Ghana.
Yeah. Luckily for me, would I say, is it post the 2016 election? I sat through the engagements that were considering a review of the National Health Insurance Scheme. One of the things that came up was this primary healthcare, free primary healthcare idea. It seemed for you and for the president, for this entire government, prevention and health promotion are two important things that our health structure must incorporate and incorporate properly. What you're doing is you are committing to overhauling the current structure.
Yes, this is a whole service delivery reform and health financing reform as well. We have to. My minister, Honorable Mentai Kando, puts it in a very, very nice way. He says that Ghana is moving from sick care to health care.
Yeah.
So our system has wholly been focused on people getting sick and coming.
And you caring for them.
Yes, and then when they come, then you take care of them. But we are going a step ahead of that. Why should you even fall sick? We need investment in that area as well. So healthcare would now look at, preventive. What can we do to actually prevent some of these disease conditions? What can we do to promote healthy lifestyles? What can we do to actually detect early some of these conditions even before they get to the hospital? Yes, we've had some very good public health interventions, immunization, ANC, PNC, nutritional counseling, but this radical reform actually expands the scope that places us in a way better position to deal with our healthcare challenges. So we are moving from sick care to healthcare.
What we need to change on the grounds? Because Karen, like you said, our system is set up for what the health minister calls sick care.
Sick care, yes.
So the whole mindset at those, even at the CHIPS compound where they are not, where the issue is not supposed to be, is more issue. The focus should have been more of prevention and early detection. But still, we engage in sick care, CHIPS, health center. You come to clinics, polyclinics. That's the same thing you see. What would have to change at all those levels so that we adapt to this new system?
So the first thing that would have to change is our own health-seeking attitude. The mindset. And it only happens with continuous engagement. So when you yourself are investing in a particular area, you know that you'd have to back it with the right community engagements. You see, so that's the first thing that we are really looking at. So we are going to use multiple channels to engage the people of this country. The minister himself will lead town hall meetings with the experts to engage particular stakeholders. We would encourage regional directors of health service, district directors of health service, working with all their stakeholders. The community health management committees provide them with resources so that they engage the population. They now plan their health and for them to take advantage of this. You see, to also encourage them. You know that, quality sometimes depends on the logistics that you have.
Yes.
So if you come and I can't check your RBS, maybe I'll just advise you, then you go home. But if I have the glucometer, I can check it for you right there and then. So I'm sure that it's been done for you. I give you the appropriate referral. I advise you don't know yet. You may decide not to go to the hospital.
Yeah.
So the 24,000 pieces of equipment will be I'm sure by now as I speak, they're on their way to the various facilities, right? So that they can provide quality.
So we have a retooling
program. That is the equipment came in about 2 weeks ago.
Okay.
I had the opportunity on Good Friday to go with the Minister of Government Communication, Minister of Health. We went to inspect it, like we'll say in the Ghanaian parlance, feely, to make sure that the thing is there. And we were actually amazed at the quick turnaround time for some of this. This tells you that we began this a long while ago, and we wanted tangibles actually, so that we will let the people of Ghana know that we really mean this possible. So it's going on. We are procuring home visit kits that would also have some of these equipment, motorbikes to assist, and then tricycles as well, especially in rural areas. They will need it to be able to transport some of these clients. And for the high traffic areas, like the lorry terminals, the marketplaces, usually they don't have too much space for construction, or some very remote areas where it's difficult to have chips compounds. We have this, the president called it containerized clinics. It's prefabricated clinics. I'm sure that you saw one of them in action yesterday. Beautiful, fitted with the right logistics, the current ICT technology. So something like telehealth, when you're within these containers, 350 of them being procured to be distributed around the country as health posts in some of these areas with difficult access. And this is definitely going to improve access. But most importantly, and what is exciting, is that you get there, the nurse there has a difficulty with seeing you, needs support, gets a doctor in the closest facility or anywhere available. They engage you by video call. The nurse would interpret or check the vitals, communicate with the doctor. The doctor will speak directly to the patient, and together they are able to prescribe a solution that requires some interventions. So if later on you have to appear in person as a facility, another facility, yes, you are referred to, but in the interim, if they have to provide some quick intervention, they do it for you. So you can see the policy intent is clear, and it's backed with the necessary and adequate resources to make it very impactful.
That's the interesting part, because typically in Ghana, people implement policies, launch it, and now try to figure out what we should do to make the policy successful.
That's true.
It seems you are clear in your mind as to the things you have to put in place. And you are putting them in place. At what point in time would we say there's a rollout of the free primary healthcare?
So once the president has declared the policy launched, it's our responsibility now to run with it. So we've been on what the athletes call the starting line. On your marks, get ready, go. So we are at the point of go. Ghana Health Service and other health service delivery agencies, CHAG, kickstarting the training of all their staff across the country. We are starting with 150 underserved districts, most underserved districts. So training is actually going on. We are also readying our systems to do the prospective payments. And as a health insurance, one thing that we are doing over the next 6 weeks is to enhance our registration drive. So we are waiving off premiums that people would usually pay, and then processing fee that people in the informal sector would usually pay. So you will get health insurance cards also for free within this 6 weeks period until the policy fully takes effect. I think it's by the 1st of June, if I heard the Minister of Health rightly. It takes full effect. So these are some of the things that we are doing, and we timed it to coincide with the policy launch, so that when we launch, there's no vacuum between the declaration of the policy and the policy taking effect. So all activities would be made known to the public, so that we can see work in progress. And so now let me say again, as a public health practitioner, public health expert, these are really exciting times for my professional life.
I see. That's interesting, because okay, now let's come to, of course, financing aspect. That is you, because it is the service will be provided for free, but it's not free for the public person. Of course, somebody will be doing some work. You have to pay the nurse who is sitting there, the health professional who is sitting there. You're providing equipment, all that costs money. How is this being paid for?
You see, this is one question that everybody has been interested in, and I am not surprised. I look at the political history of this country when it comes to implementation of social services, and it has been something that
one story after another,
one story after the other, and especially with the suboptimal implementation of the free SHS, people are
even the National Health Insurance Scheme. You remember at some point we're discussing whether to do co-payments.
Co-payments,
you recall that?
Yes, I recall that.
Every one of our policies have had the same challenge.
Has had the same challenges. So people are wondering, hey, this is so much you are going to do. Are you sure that you'll be able to fund it?
So this is a question that has been directed at you.
Yes.
Even privately.
Privately. Okay. People always ask. The good news is that, so we look at it objectively.
Okay.
As health insurance, one of our key mandates, I talked about health sustainability when financial health finance and sustainability in my introduction, when we were talking about the major gaps that this policy seeks to address, taking ownership of some of these interventions. You know that health insurance is our fund, 2.5% of the VAT that we pay goes to the National Health Insurance Fund. For formal sector workers, 2.5% of your SNIT contributions would go to the National Health Insurance Fund. You know the genesis of VAT. It was established under the Rawlings regime and so on and so forth. So the lifeline of National Health Insurance Scheme actually comes from the VAT that was established by the Rawlings regime, and subsequently Rawlings regime started the pilot of the NHIS, which became full-blown in 2003. It got to a point in 2017 or 2017 or 2018 thereabout, where the government decided that they are going to slice off some of the NHIF, National Health Insurance Fund, and use it for other things. And this will certainly have implications on our current health expenditure.
Because even at the time they said the money was not enough.
Yes.
Then they started taking away some.
They took away as much as 40%. So you go to in the year 2024, the collection from taxes for NHIF was about 9 billion, but I think what came to the NHIFS was about 5 billion. You see, President Mahama, with this vision, said that, listen, he's given the people of Ghana this commitment. Okay. You see, health is a basic human right. It's one of the key social interventions that contributes to socio-economic development. It deserves the right investment. Okay. So when he comes as president, he was going to take off that cap. Okay. So that's uncapping of the National Health Insurance Fund. And by the second month of 2026, of 2025, when he came to power, he had uncapped the National Health Insurance. So for the first time in history, what was budgeted for, what was collected, and what was actually transferred to the National Health Insurance Scheme was converged.
Okay.
There was that convergence.
Okay.
So we're supposed to receive about 10. What was budgeted was about 10 billion. What was collected by Ghana Revenue Agency was about close to 10 billion, and everything was transferred to the National Health Insurance Authority. So out of that actually comes, out of that political commitment for the president, gives birth to the health financing foundation of the primary health care. Additionally, every good policy, if you have a policy endorsed by no meaner person than the WHO Director General and a lot of international partners, you are definitely going to get development partners ready to support. So there will be complementary funding also from development partners. But we as an insurance, even working with what we have, what we actually did was to make sure that we do our fiscal space analysis. You look at how much you have and what pressure is on the funding that is coming in. Then what space you need to actually add on. Then you do what we call the actuarial projection. So what will be the utilization? So we are asking people to now working for free. What would be the bill that we have to pay as a people? So we calculated all that. So with our projected revenues, right, are we able to meet this service package? So that would also influence the kind of service package that you start with. So we start with the most impactful public health interventions at this time. So all this was done. 1.2 billion cedis made available for the policy this year. We projected into the next year. And then when we expand to 261, all 261 districts within the country, and then when we begin to add on interventions like cervical cancer screening, is one of the leading causes of deaths amongst women in their fertility age and even beyond. Cervical cancer, for men as well, prostate cancer. These ones have not been onboarded yet. And the reason why it's not been onboarded. Number one, we don't have that capacity. And then we are also gradually expanding our physical space to be able to accommodate more. So as a responsible government, we will make sure that we have funding plans or funding arrangements available before we go out with these very ambitious policies. And this is actually not, so this, I'm talking about current health expenditure, what is spent actually on health. But you see, the president with his vision for healthcare actually also has instructed all the district chief MMDCs, Metropolitan, Municipal and District Chief Executives that, listen, with your common fund that is, make sure that you have invest money available to complete all existing health projects that were started by previous regimes. And in addition to that, construct a CHIPS compound every year. And you looked at projects that were started with Ghana Infrastructure Investment Fund. That's Agenda 111.
Yes.
Something that was instituted by Mahama One administration, accumulated money. That money was used to start Agenda 111 hospitals. And then after spending close to, is it 5 billion cedis? 4.8, yes. 4.8 billion cedis also. On these hospitals, we have none complete. And the president instructed the Minister of Health that find means, workable solutions to ensure that we get these hospitals running. Because after all, the Ghana Infrastructure Investment Fund is something that I instituted. If another government came to use it without the appropriate planning to finish these projects, it doesn't mean we should leave it in a balance. We have to complete it. So there will be partnerships with the private sector, Christian Health Association of Ghana. All these things are going on so that these projects are completed. All this in addition would certainly complement what we have as a health sector at this point. And I'm sure that we would have, when we are talking about health finance, and there's no way we can talk about, end this discussion without talking about the Ghana Medical Trust Fund, what we all affectionately
because I was going
call
to
the Mahama
add
Cares.
that to conclude our interview, because our time is already up. But I wanted to find out one, would it, because when you say free, people are assuming that then you will not have any complementary payments from the person you're providing the service to. Would that increase the pressure on you, the National Health Insurance Scheme? What are your projections?
Yes, we have to anticipate that our expenditure would increase, and we've planned towards that. So that is what the actuarial analysis I talked about, the actuarial projections I talked about. Yeah, so we know that once you say people should come for free, those who hitherto would not come to these primary care healthcare facilities will now come. They will come, and we have to pay for it. So we know we know that our expenditure, our liabilities would increase by as much as 30%. And we've costed all that, and we've made financial arrangements to take care of it.
I see. Very interesting. Then I said I will conclude with, of course, we'll find time and talk about the National Health Insurance Scheme itself.
Yes.
Because there's a discussion that we must have. But I said I will conclude with that because I heard one member of parliament who says when they come into office, they will abolish what is... I don't know why Mahama Cares sticks in mind.
Ghana Medical Trust Fund, affectionately called Mahama Cares.
Ghana Medical Trust Fund. Because his argument was that it's a duplication of the National Health Insurance Scheme. Is it true? Is that accurate?
So that is according to his limited understanding.
Okay, that's a limited understanding.
Yeah, according to his limited understanding, or perhaps his strategy that he wants to use.
Okay.
But trust me, there are so many examples from other countries. You go to Kenya at this point, they have separate funding for primary health care. They have separate funding for creative. They have separate funding for emergency and chronic care.
Okay.
That's it. You go to a country like Ethiopia. So they have separate funding for community health care, like the free primary health care.
Okay.
Community-based health insurance, so they call it CBHI.
Okay.
And they have a second layer, which is the social health insurance.
Okay.
So there are reasons why you want to bring in innovative ways to mobilize more funding for some of these conditions.
Okay.
You see, if you understand the Ghana Medical Trust Fund and what it seeks to do, yes, there's a certain foundation funding that will come from the National Health Insurance, 20%.
Okay.
But you see the innovative drive that is going on, mobilizing resources from private sector and all other development partners, specifically to take care of catastrophic cost.
Okay. Catastrophic
cost. It's catastrophic for a lot of families, because when somebody has kidney disease now, the amount of money that goes into treating that person is able to collapse a whole household economy. So you want to have a fund that is separate, that can actually also benefit from innovative means of raising funding to complement what is there. So there's a pure focus on dealing with complications from non-communicable diseases. And at this time, that it appears to be one of our biggest challenges. You isolate it and you put in particular interventions to deal with it.
Okay.
And that is exactly what we have done. And the results would actually show for itself the wise reasoning behind this vision of the Ghana Medical Trust Fund. And as for everybody relying on the proceeds of tax, why not? I mean, I just mentioned to you that value-added tax established within the Rawlings regime, out of that 2.5% was used to establish the National Health insurance scheme. So is it surprising? Get Fund, established in 2000 by the Rawlings regime, that significantly contributed to the establishment of the free SHS. So sometimes it is disingenuous for anybody to make reference to the source of funding as perhaps a particular pet project of one administration. So once there's a connection to that source funding, then it means that it is nothing novel. That is actually not how to build a country. At every point in time, we require tailor-measured solutions that would actually depend on the available resources of the country to develop it. So that is exactly what we are doing. And you heard how gracious President Mahama was. You see, this has come to complement the National Health Insurance Scheme, both the Ghana Medical Trust Fund and the free primary health care. He's not going into any of these tangential debates. What is important is delivering health care to the people of this republic, and exactly what we are doing.
Well, thank you. Thank you for making time to join us, Doc. Dr. Kwesi Djokoto is Deputy CEO in charge of operations for the National Health Insurance Authority. So he's the right person to have asked, what is the state of our health insurance?
Yes.
Among others.
This is my home, so
yes.
So, certainly at your earliest availability,
yes,
you can call me back in.
Yes, because I'll really, well. Because National Health Insurance is one of the interesting thing you're doing, free primary health care, then move to the district level, to the regional level, and the way in which you are tailor-making every funding decision is quite impressive.
Thank you very much.
So that's quite an interesting thing to watch.
For God and country.
Yes, quite an interesting thing to watch. So a big thank you to Doc, and of course a big thank you to you for making time to join us on the show today. Like I said, I promise you, I'll bring Doc back. We'll talk about National Health Insurance Scheme. Just to say this from Dr. Samson Obedapia came in early, actually. Please, I'm not a lawyer, but I am confused here about this OSP and AG issue as follows. So at this time, our parliament and lawyers were passing this OSP law. Didn't we see this coming? So during the tenure of Martin Amidu, was the OSP taking prosecutorial powers? You see, okay, so I am hoping that the interviews we had with the lawyers really address the issues that you had in your mind on this matter. But, well, we just discussed free primary health care, and trust me, this is big. It's very, 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 very big. Well, a happy birthday to Fatima Atta Mohammed of Ministry of Food and Agriculture. It's from Alberta of Enterprise Insurance to Fatima Atta Mohammed of the Ministry of Food and Agriculture. We'll see you tomorrow with another edition of the Gold Morning Conversation.